the cornea is continuous with the sclera. They're basically one continuum, the sclera going into the cornea. But the lamellae of the collagen are spaced differently and are of different thickness in both of them. That is why one is totally white in color, the other is totally transparent. The cornea is an immune privileged tissue. That means that if we do a keratoplasty, then the chances of a rejection are much less because there is no blood or lymphatic drainage of the cornea. We know it is avascular, but there's no lymph as well. It is one of the most densely innervated tissues in the body. Now, this has a lot of clinical relevance, especially if we look at dry eye. Initially, the thought was that tears are produced in a baseline manner, and if something goes in the eye, there's some stimulation to the corneal nerves, then you have reflex watering. Now, what the understanding is that all of the tear production is reflex. The cornea is so sensitive that even if your eyes are open, that stimulus to the cornea, that is what is responsible for the normal production of tears. If there is a neuropathy of the nerves are not functioning well in the cornea, the sensations are less, you have a herpes zoster, you have a diabetic, they will have dryness of the eyes because of the loss of sensations, because all the tearing is reflex. There are two plexuses, one is subepithelium, one is in the stroma of the nerves. And it is one of the most densely innervated tissues in the body. There used to be 5 layers of the cornea: the epithelium, the Bowman's, the stroma, the desmes, and the endothelium. Now there is a recognition of a 6th layer, which is just behind the desmes membrane, called the Dua's layer. So in certain surgeries that we perform, this has a significance. The cornea is responsible for most of the refraction of the eye. If the whole eye has 60 diopters of power, then 2/3 of it, 40 diopters, is from the cornea and 20 diopters only from the lens. Now you can see that the lens is actually a biconvex structure. The curvature of the lens is more than that of the cornea. But the reason why the cornea is responsible for most of the refraction is because the refractive index of air, which is 1, and that of the cornea, 1.376, that difference is very large. Okay, so the lens, 1.33, is of the aqueous and vitreous, and 1.41 of the lens. That difference is maybe 1/4 or 1/5 of that difference that we have from the air. So that is why the cornea bends light much, much more. And any irregularity in the cornea, the bending will be much more marked than at the lens level. So it forms the anterior 1/6 of the eyeball, and it is not a perfectly spherical structure. It is more precisely mentioned as prolate ellipsoid, but the central form is almost a spherical structure. That is the most important for our vision. So the function of the cornea is one, it is strong and clear as glass, but it has to protect the structures of the eye. It has to be strong and durable to prevent anything from going inside the eye and getting injured in its by itself. Now, within the cornea itself, the front 1/3 of the cornea is much stronger than the back 2/3. The collagen in the front 1/3 are interlinked more. They have anterior-posterior branching as well. And the proteoglycans which are present in the anterior 1/3 are more of the dermatan sulfate, which is a little tougher. And the posterior 2/3 has got more of keratan sulfate, and the collagen are thicker. The collagen if we do a surgery, the posterior 2/3 can easily dissect the anterior one that's written here, and it has other harmful matter, that is the from entering into the eye. It absorbs most of the UV light, And we know UV light is responsible for inducing a cataract, inducing age-related macular degeneration. So the cornea has a protective function to, so it acts as the eye's outermost lens. Now, if there are any questions, we can take it up. Otherwise, we'll move to the diagnostic tests for corneal diseases. So diagnostic, the most basic is torchlight examination, where you'll be able to pick up very, if there's a big opacity of the eye or the cornea, you'll be able to see that. If there is a keratoconus, you make the patient look down, you'll see a fold come, a V-shaped pattern on the lower lid that we call Munson sign. So if you put light from the side and the chamber is very deep, you can diagnose some case of keratoconus. But by and large, the slit lamp biomicroscopy is felt to be one of the most basic examinations of the cornea. Now, when using a slit lamp, there are some particular views which are very useful in picking up faint opacities or even very faint epithelium changes. One of these is sclerotic scatter. So any patient, if you want to see if there is a corneal disease, even a faint one, the first thing you should do is a sclerotic scatter. In a sclerotic scatter, what we'll do is, first of all, we know there is an illumination in the viewing system, observation. The illumination and observation are always coaxial. That is, if you're looking at the cornea, the light will come on the center. So for a sclerotic scatter, you have a knob in most of the slit lamps. You open the knob and you'll be able to free the illumination system from the viewing system. So you have to decenter the illumination to the side, to the limbus, so that you're still looking at the cornea, which is in the center, but the light has moved to the side, to the limbus. So a bright light at the limbus will then go through the cornea to the rest of the limbus. So that travels by total internal reflection. And anywhere there is a corneal opacity, anywhere there's an epithelium aberration, anywhere there guttae, that place will leak out the light and that will immediately light up. So a sclerotic scatter is a very useful way of detecting any abnormality within the cornea. The other one is a retroillumination if the patient is dilated. So you put light into the eye coaxially, and the red glow comes from the retina. And through that red glow, any cystic changes and opacities will be highlighted. Other than that, there are a number of instruments which are available which can tell us more detail about the cornea structure and function. Those include the corneal topography, starts with the keratometry and a full topography, corneal thickness evaluation, pachymetry, specular counts, evaluation of endothelial cells, epithelial integrity, corneal vessels, and also functional abnormalities can be tested. There are also other tests which are done by us related to the cornea, like checking for tear film abnormalities, a Schirmer's test, or a tear film breakup time test, inflammation and infection MM69, not commonly done clinically. So we all know that the way to assess the curvature of the cornea is by a keratometry, keratoscopy, video keratography, or a topography. So all of these are very important in a number of situations for us clinically. If we want to put a toric lens while doing a cataract surgery, now we need to have a lens which is going to negate the corneal astigmatism. So we have to make sure that there is a regular corneal astigmatism, which is when this will work. And the extent and the axis of the astigmatism should be accurate, so that when we put the lens, we can orient the toric lens in the correct direction, and that will negate the cylinder in a proper manner. If someone wants to go for a LASIK or a refractive procedure of any kind, the cornea should have sufficient thickness and sufficient strength. There are a number of markers on the topography which can tell us that this cornea is not so strong, an inferior steepening, or even a number of company provided indices which will tell you that this is a normal cornea or abnormal cornea. Then to make early diagnosis of corneal shape abnormalities like keratoconus, PMD, TMD, and it also helps in contact lens fitting. After cataract surgery, if sutures have been put, which is rare nowadays, removal of sutures or after keratoplasty suture removals can be guided by the topography. You remove it from the steep axis and reduce the astigmatism. So this is what we used to do when I was in my MD days. That is a video keratography. That is, there is a placido ring, a number of placido rings that is reflected off the cornea. The computer is going to look at the reflections of the placido rings, and wherever the reflections are more compressed, they're closer together, that part of the cornea is steep. Wherever they're further apart, that part of the cornea is flat. So by taking all the data points from all the multiple rings, more than 5,000 data points, it reconstructs the curvature of the cornea. It color codes them. A steeper one is a hot color, a warm color like reddish, and a flatter cornea is a cool color towards blue, so that we can, by looking at the colored map, we can get some idea of the curvature without having to look at all the values, and that will tell us about the patterns as well. So the disadvantages of a video keratography is it will not image the posterior part of the cornea. So it will not tell us the pachymetry, the thickness of the cornea, and posterior corneal abnormalities will also not be picked. So now we do corneal topography. We can also call it tomography. So this is not just a placido disc ring reflection, but in addition to the ring reflection, we can use some kind of light which has gone in a slit from side to side and all the data points captured. So it is taking reflections from the front and back of the cornea. That is called scanning slit, or Scheimpflug or dual Scheimpflug image, where two cameras will rotate and they will also take multiple optical images and reconstruct it into a three-dimensional structure. So by taking the posterior part of the corneal images as well, we're able to do a subtraction of the anterior and posterior and get a keratometry map. So the pachymetry map, corneal thickness map. It'll tell us how much the thickness is at each and every point. So we can, according to the settings, choose how many points it will show us. If we put the cursor here at this point, it will tell us that the thickness at this point is this much. So we can see what the thinnest point is, we can see what the pattern is, and we can also compare it with the other maps. So the second thing that we see, this is common between a topography and a video keratography, just a placido, is the keratometry map. This will tell us what the effective curvature of the cornea at each and every point is. So in this particular patient, the particular topography we have here, it is showing us an asymmetric bow tie. So a bow tie is something you can wear here. Now that is usually a symmetric one. Now in this one of the two cloths is small and one is very big. So this is an asymmetric bow tie. And along with that, the axis of the two bow ties is not the same. If one is like this, the other is like this. So a 15-degree difference between the one axis of the bow tie and second axis of the bow tie, that is also not a normal feature. So an asymmetric bow tie can be seen here with curvatures of more than 54, which are definitely abnormal. Usually 47.2 is a cutoff. Beyond that is always to be regarded with suspicion. So this is quite characteristic of a keratoconus, an asymmetric bow tie. And then it can also tell us what the curvature in each and every point is. Then the third map, which we get, is the anterior elevation map. So anterior elevation map is a means of depicting a 3D structure, like the curvature of the front part of the cornea in a two-dimensional manner. So it is not a very easy thing to do. So what we need to do is the curvature of the anterior surface has to be compared with some reference structure, so that we can say, okay, the reference shape is like this, your shape is like this, some is above, some is below. Whatever is above, we make it the warm colors. Whatever is below, we make it the cool colors. So that is called the best fit sphere. So it makes an imaginary sphere which kind of best averages out the corneal curvatures, and whatever is above that is a hot color, whatever is below that is a cool color. So that way we can represent a three-dimensional structure in a two-dimensional map which can be printed out. So in this particular case, he's got a very high anterior elevation, maximum of 31. Usually 15 and above is regarded as abnormal. So this anterior elevation map will tell us that this is where the cornea is bulging from. And the fourth one is the posterior elevation map. The posterior elevation map is the same thing, but done from the back part of the eye. So in this particular patient, you can see that the back part of the eye is even more bulging forwards than the front part of the eye. And this is a case of a typical keratoconus. The corneal thickness is not that bad. The curvature is quite steep. So as is common, it's a inferotemporal kind of a cone. So tomography has given us so much of an insight about the cornea's thickness, its shape, and its features. If we want to treat, this will give us a lot of data. We can also see for progression over time by doing serial maps. And if we treat, we expect it to not progress any further. Then there is an anterior segment OCT. Anterior segment OCT. Yeah, so you can post your questions here. Anterior segment OCT is an optical coherence tomography, which will map. It's like an optical cross section of the cornea, which can be obtained. So there are 7 things which we can use the OCT for: determining the corneal thickness. And if someone has had a LASIK surgery, we'll be able to see some white line there that will tell us this is the position of the flap. So what is the flap? What is the amount of cornea behind the flap, which we call the residual stromal bed thickness? We can measure both of these. Depth of corneal lesions, including dystrophies. Now, if it is a superficial dystrophy, we can just use a excimer laser and clean it off. It is extremely deep. We'll have to probably do a partial thickness cornea transplant. If it is full thickness involving the descemet membrane, we'll have to do a full thickness. So this gives us a guidance, an exact depth of the cornea opacities, including dystrophies. Details of corneal inflammation can also be made out. An inflamed cornea will have a lot of this white spots, kind of a disturbance. Descemet membrane assessment. This is sometimes useful after cataract surgeries if we are suspecting a descemet membrane detachment. So the cornea after the surgery is edematous. There is some bulle formation. We do this and we see that the descemet there is detached. So then we know, okay, if we take the patient back to the OT, put an air bubble, that is going to put this back in its place and the cornea will clear out. So this helps diagnose that. Then deposits in the cornea, whether it is dystrophies or foreign bodies. Dry assessment, diagnosis of ocular surface neoplasia in early stages. Because neoplasia will have the optical structure of the epithelium. Even if it is on the conjunctiva, the mesenchymal part won't be there, but the epithelium part will be thickened. So that tells us that this is not just a corneal conjunctival degeneration, because the epithelium part is thickened out. It is a surface neoplasia. Try and change it from here. Yeah. So like this is one of our patients. He had a history of vernal keratoconjunctivitis severe since childhood. Now he was 24 and he had a lot of photophobia and glare. So we saw that the opacity was in the anterior 192 microns. So here it's 208. So this is amenable to a laser. We call it a phototherapeutic keratectomy, where with laser we're going to be cleaning this out. And we will have 495 microns of residual cornea after the laser. So that is a good enough thickness to maintain the structure of the cornea. Then the next diagnostic modality we use is a specular microscopy. Now the endothelium is required to keep the cornea clear, because we know if the cornea becomes edematous, if it accumulates water, then the collagen lamellae distance gets all abnormal and the cornea loses its transparency. So the pump of the cornea is endothelial cells, and they need to be there in sufficient numbers, at least 1,500, in sufficient quality, hexagonal in shape, not very large, not very varied in shape. So that we can see by a specular microscope. Now here we can see that there are a lot of nearly hexagonal cells. The cell density is 2,800, 688, which is reasonably good. There is one guttata, so it is not a very bad cornea. It is good. It should withstand a surgery, and the cornea should be clear. So not just the number of cells, but also the quality of the cells can be seen by a specular microscope. We can actually see the same thing on a slit lamp ourselves, but then counting it and quantitating it is not possible on the slit lamp. But if you see this specular reflection, you'll be able to see the same thing. And you can see if it is hexagonal or different size, very large cells, or difference in the shapes of the cells, so polymecathism, pleomorphism. And that will, just for a rough idea, we can make out. And then finally, in the biomechanical diagnostics of the cornea, biomechanical diagnostics means that we're trying to assess how strong the cornea is, the strength of the cornea. So we have measured the thickness, that gives us some idea. We have measured the corneal curvature. If there is an inferior steepening, that is a sign of an ectatic cornea. But what if the cornea is still normal, but it is weak? And if we go ahead with maybe a laser, it will weaken further and then start showing us all of these topographic abnormalities. So with that aim in mind, there have been a number of tests, investigations which have come up, which will tell us the corneal strength. Also, when we are measuring the intraocular pressure, we measure it through the cornea. If the corneal strength is a lot, we'll have to push through more before we reach the intraocular pressure. We'll get a false value of the intraocular pressure. So the most commonly used one is a ORA, Ocular Response Analyzer. It works very much like the non-contact tonometry. A puff of air goes, the cornea is curved, it flattens out, and it curves again. Now, if it is a strong cornea, it'll take longer to flatten out and longer to, almost still in milliseconds. So this measures that how fast the cornea is going to flatten and go out, and gives us a value of how strong the cornea is.
Recording stopped.
Recent tests like the optical microscopy. So this will give us in vivo measurements of the strength of the cornea lamellae by putting an IR light and seeing the reflections from the cornea. So all of these basically are trying to give us an idea of how strong the cornea is. And they're still more or less in the investigational stages. If you want to do a study, you use them, and not into very much clinical practice.
Recording in progress.
There is also the confocal microscopy scanning. Now with confocal microscopy, we are able to see a very, very detailed image of the cornea. We can see amoeba cells in the cornea. We can see different deposits of different structures. So we can see an in vitro histochemical study. Like it's almost like you're doing a pathological specimen mapping. So it is a non-invasive technique where we can do in vivo imaging. So it is again not very common in widespread use, but very useful for certain conditions like Acanthamoeba Keratitis. For some neuropathies, you can see that the nerves are not present. That's why the dryness is being caused. And the contact lens, how much it has affected the eye. Things that can be made out with this. The aberrometry used to be so much more in vogue about 10, 15 years back. What it measures is that not just the cornea, but the whole eye, how much refractive power is there, including the cornea, the lens, the vitreous, the curvature of the retina, everything together. What is the final power of the eye? And then it divides us that it measures that how much sphere there is, how much cylinder there is, how much coma, how much trefoil, how much quadrifoil, how much spherical aberration, all the tiny errors can be measured by the abrometry. So we used to do a lot of customized LASIK and PRK using the abrometry, but because it is not such a constant measurement, with age, with the changes in the lens, with the hydration, the abrometry keeps changing. So gradually we shifted from trying to treat the abrometry to just measuring it to get some more accurate refractions. So we'll just come now to the refractive surgery and a little bit about the advancements of the refractive surgery. So it started off in the 1990s as a PRK, photorefractive keratectomy, where the epithelium is removed and this light blue convex lens here, that is what the laser is cutting out on the surface of the cornea. So it was a more simple thing: remove the epithelium, fire directly on the cornea, put a contact lens and let it heal up. Then the healing time was more, there was pain, there are other complications of PRK. So we moved to something called LASIK. Although PRK is still relevant, but LASIK gives us much faster rehabilitation. So we make a small flap, we remove the same amount of corneal tissue as in PRK, the same kind of a convex lenticule is removed, so the cornea is flattened. All of these refractive techniques, the essential thing is the cornea curvature, if it is 44, you make it 40. If the patient had -4 power, it becomes 0. So mota, like it's like that, but not the exact thing. You may have to remove a little more than 4 to treat for 4, but that is the essence of it. So a flap surgery has the advantage that the smooth epithelium is reflected and then put back. So immediately the patient is able to see clearly because the epithelium is immediately replaced back into its position. So that smooth, shiny surface is replaced from the next day the patient is seeing very clearly. And the third and the most advanced one that is there now is called the SMILE. So it's a small incision lenticule extraction. So the laser is cutting out just a lenticule in the stroma, making a small side cut, and we remove the lenticule from that. So it is like a laparoscopic SMILE, laparoscopic LASIK. So you don't make the whole big incision, but a small one. So even in today's date, PRK has some relevance because there is no flap creation. If someone is going to the armed forces, he has contact sports, he'll get punches on the eye. A LASIK flap can move even a year, 2 years after the LASIK. A LASIK flap can move. Surgically, if I want to lift up a LASIK flap 2 years, 3 years after the procedure, I can go into the OT and just lift it up. It's not very difficult. So it never heals up properly. But in a PRK, there's no flap. So in such patients, it is very good. Then patients with dry eye, because they're less damage to the nerves in PRK, it's better for them. It's not suitable for patients, of course, very dry and nothing is suitable. And it takes much longer to recover from a PRK than a LASIK. It can take up to 3 months for the sharp 6x6 vision to come. Most people are very impatient in today's date and age. They don't have so much time to sit at home. And first 2-3 days after PRK, there is some pain. So nobody likes pain if it can be avoided. So this is a small animation video of the PRK. So the first thing we're doing is we're putting a well in this. We put a drop of alcohol. They've scored the epithelium. That's okay. This is the alcohol that is put. About 60% alcohol for a period of 15 seconds is sufficient. We wash it off without letting it touch the limbus. We scrape away the epithelium. Now we have the Bowman's membrane directly exposed to us. With laser, we're going to reshape the cornea. We take this opportunity to remove all the aberrations of the cornea through the topography. And then we put a contact lens, wait for 5-6 days. Behind the contact lens, it will heal up. The contact lens is put so that the blinking movements don't disturb the healing of the epithelium. So it makes two different, one behind the contact lens, the epithelium can grow and the lid is not going to keep disturbing it. And 5-6 days later, you move the contact lens and the patient is usually seeing 95% of what he will. In a month or two, it becomes 100%. So LASIK is, again, there are two ways of doing LASIK. One is we lift this flap using a blade assembly. It is a specialized microkeratome, we call it, that makes this flap creation. The second method is we use a laser to make this flap. So I'll just show you an animation of a LASIK. So in this, the epithelium is not going to be disturbed. So we're through laser, we're making small cavitation bubbles in the stroma, and then a small side cut, 20 millimeter side cut. It's like leaving 60 degrees, 300 degrees cut. Then this flap is lifted off because the cavitation bubbles are like stamp papers. You just cut through them and you get a flap. Then the laser is done. A customized laser can be done, which will treat the sphere, the cylinder, the coma, the trefoil, all the fine powers, and in an attempt to improve the vision beyond spectacle vision. The flap is placed back. In 10 minutes, it sticks on. And the next day, the patient is seeing well. So the third one that the latest one is the smile. So advantage of smile is, again, there is just a small 2 mm incision. So the chances of a flap, it's a flapless technique. And it also has the advantage of LASIK, that you have not disturbed the surface of the eye. So the cornea stays smooth and shiny, and the patient gets good vision from the second day after surgery. So this is a small animation of the smile. So in this, the laser is first put in a posterior, the posterior cut is made, then the anterior cut is made, and between these two is a convex lenticule. The same lenticule that would have been ablated by the excimer laser is now just shaped out. And then a 2 mm incision is made in the cornea, and through that we go and we remove this lenticule. So it combines advantages of PRK and LASIK, less of dry eye, no flap, well, with recovery of vision, which is quite quick. So so if we look at the advantages, so this is a more expensive technique than the LASIK, because the royalty that the company asks for is much more. So typically 1 lakh and above would be the cost of a smile for both the eyes. So coming to corneal ectatic conditions. So corneal ectatic conditions are a group of conditions that affect the cornea. Conditions like keratoconus and PMD are felt to be part of the same spectrum of conditions of corneal weakness, pellucid marginal degeneration, and a few patients of post-refractive surgery corneal steepening, those patients who had slightly weaker corneas and the refractive surgery has weakened the cornea further. So we call it post-LASIK ectasia. Those also come under the corneal ectatic condition. So the treatment of corneal ectasia, of course, the rehabilitation would be first spectacles. If spectacles don't work, then rigid gas permeable lenses or scleral contact lenses. We'll go into that in more detail. And if these fail, then surgical treatment or laser treatment. And deep anterior keratoplasty is performed as a last resort. In today's date, the keratoplasty for keratoconus is much less, because the contact lenses are able to give very good vision to even advanced cases of keratoconus. So we'll go into that in a little more detail. How do I change there? So the semi-scleral contact lenses, let me just go to the picture first. So this is a contact lens which is going to be resting only on the sclera. It's not going to touch the cornea at all. It will vault over the cornea. And between the sclera and the cornea, there will be fluid that will be placed. So the patient takes the contact lens, we put the balanced salt solution. It is inserted like this so that the fluid stays between the cornea and the lens. No air bubble is allowed to enter. And this fluid will stay the whole day. In the night, when the patient takes the contact lens off, the same fluid will be there that he started with. There is no fluid tear exchange which takes place. So you can see that this patient has such an irregular cornea here, but the contact lens has given him a smooth surface. Now, why does it work so well? Because it is changing the corneal curvature at the point where most of the diffraction takes place. That is between the air and the lens. Before it was the air and the cornea. Air is 1.6. Now the refraction. So the difference of the refraction here would be much 6 and 1, but now it is much less. And that new surface is the one that we have put there. So yeah, so this can treat very advanced, or even this is a post-PK astigmatism. So you can see it was such an irregular cornea. Once we put the lens, we have a new surface. This is again an anterior segment OCT of a patient with a keratoconus. Now these are extremely high oxygen permeability materials which are used for scleral contact lenses. They are semi-soft. That means that they are quite rigid, but not glass. And typically we have over 100 DK value, so that the oxygen permeability is very good. They are also used for patients who have severe dry eye, extremely severe dry eye, because the water that you're going to put there will stay and hydrate the eye the whole day. So those cases do very well with semiscleral contact lenses as well. So if we go over it in a more systematic manner, so they're designed to vault over the entire corneal surface and rest on the sclera. So it morphs an irregular cornea to a smooth surface to correct vision problems. Indications are corneal irregularity, ocular surface disease, severe refractive error. In the West, people use it for myopia as well, but not in India. There are expensive lenses, 35,000 at least for one lens. The advantages, we can take care of any severity of corneal steepness. That is why all these very severe keratoconus patients, we are not doing keratoplasties for them, because the moment you put the lens, he's reading 6/9. You're like, if you're happy with the contact lens, we're happy. 6/9 is not a vision I want to operate you on. So they provide better centration and stability than corneal rigid gas permeable lenses. If the cornea is like this, the corneal lens will not be stable at all. So corneal lenses are very useful for early cases, but severe cases, they're just not possible to use. And they're very comfortable. Once a patient wears them, he doesn't feel the irritation of a corneal contact lens. The drawback in India, cost. And second, wearing it is not so easy. The patient has to spend some time sometimes why making husband wear it, and obviously lens, and that blurs the vision. So you have to take it out, replace the fluid, wear it again. Those factors are also there. We had some. Sir, can you please explain about the measurement of each layer in ASOCT? Is it automatically measured by the instrument? Is it possible to do it on OCT fundus camera? So we'll just go to the, yeah, so this is a picture of an anterior segment OCT. So the OCT machine is not going to automatically measure any thickness for you, but you'll be able to see that. You can see the top layer here is the epithelium, and you will have calipers with which you can put at the top and at the bottom and measure the thickness for yourself. Structures like the desmae and the endothelium, which are very thin, are very difficult to actually measure perfectly. So it is essentially for opacities, for the epithelium, for the total thickness, which a measurement can be done. And definitely with TopCon, they have the calipers. You can use the calipers to measure with the TopCon OCT. The second is, what are the exact criteria for deciding about the choice of refractive surgery? According to all parameters like sphere, cylinder, keratometry readings, pupillometry, tear meniscus, some patients are making you think a lot to choose the right option, whether to go for LASIK or PRK or femtoLASIK. Please explain. So the criteria are: one, the thickness of the cornea. If the cornea is more than less than 490 microns, then a LASIK should not be performed. Okay, I'm unmuted again. So very thin corneas, do not go for LASIK, go for a PRK or a smile. Because in a PRK, there's no weakening of the cornea by making a flap. It is better. Because in a smile, there is no flap. It is better for the corneal strength. Second, if there is weakness in the eye, then, if there is dryness in the eye, then again go for a PRK or a smile. LASIK induces the most dryness compared to PRK and smile. Third, if there's some superficial corneal opacities, go for a PRK because that will clear that off as well. But by and large, most patients that we see, all options are there for them. Whatever is in their budget, they can go for it. And the visual result of all of them is the same. Is that the strength is more in PRK or smile compared to LASIK. FemtoLASIK or normal LASIK, they don't have too much difference between them in terms of results. But in the normal LASIK, the pressure that is created in the eye when we're passing the blade is about 100 millimeters of mercury. So it causes a bit of a, the patient can't see anything, not even light. When we put the ring, we say, is it all dark? He says, yes, then we pass it. So the blood circulation to the whole nerve, to the retina is all stopped for a minute. So that high pressure can have some consequences in the past. The femtosecond is more gentle, but immediately the patient will not notice any difference. And if he can afford it, femtosecond LASIK is more gentle. Presbyopic LASIK is a very detailed topic. There are many ways of doing it. The most reliable one is a monovision. One eye for distance, one eye you leave a little bit of a myopia. And with that, with both eyes, he'll be able to see together. Now, all of us have one eye, which is a dominant eye. If we are pointing, we are looking through the dominant eye to what we want to see. So the dominant eye should always be focusing for distance. In the non-dominant eye, you should always set it for reading. Whether this is during LASIK or this is during cataract surgery, this should always be followed. If you do the reverse, the patient will be miserable. So presbyopic LASIK, most of them work on the principle of monovision. They also increase the depth of the focus so that the distance eye can see some intermediate. And the near eye can also see some intermediate. So both of the two zones are blended. Then the brain can fuse them more easily. Another question is, sir, does rubbing of the eye result in keratoconus? So keratoconus will not happen if a normal person rubs his eye. But if there is someone who is predisposed to keratoconus, then rubbing of the eye is the only modifiable risk factor that we know. So the patient, if he asks, what can I do so that my keratoconus does not progress? We say, don't rub your eye, because rubbing the eye makes keratoconus progress. But this is not to say that if anybody rubs his eye, it will cause keratoconus. So eye rubbing is a modifiable risk factor, but not the cause of keratoconus. So does stimulation of the cornea reduce dry eye? Stimulation of the cornea causes the watering, but how do we continuously stimulate the nerves? So most of the patients with dry eye, their nerves are not so sensitive anymore. There's some neuropathic element, whether it is due to overuse of contact lenses, diabetes, some neuropathic viruses like herpes zoster, herpes simplex. So that sensations are less, but something can be done to increase the stimulation of the cornea to treat dry eye. I'm not aware of any such treatment that exists right now. How common is corneal ectasia post-refractive surgery? So it's quite uncommon. We are generally seeing patients who are operated very in the early stages of LASIK, like 2000s, early 2000s, coming to us with with post-LASIK ectasia, because at that time the flap that used to be made was not 100 microns like we do now. It was 200, 220 microns. So it was very injurious to the eye. And then they used to treat extremely high powers, minus 12, minus 14, minus 16. So in that case, it is but obvious that the cornea will give way. Now, with further understanding, you can say that maybe 1 in 10,000 or 50,000 people would have corneal ectasia. It is much less common. What causes keratoconus to get worse? Keratoconus, there is only one modifiable risk factor, that is rubbing. Otherwise, generally, with time, keratoconus is going to get lesser. But there is a treatment of keratoconus. And the treatment that we do for keratoconus is called a C3R. So C3R is a means of inducing cross-links between the collagen fibers in the cornea. So it is corneal collagen cross-linking. 3 C's, cornea collagen cross-linking, and then with riboflavin, the R. So C3R. Now, a normal cornea has a strength, let us say, of 1. A person with keratoconus usually has a strength of 1/3. So their corneal lamellae are loose. So with the normal pressure of the eye itself, it is going to bulge. What we're trying to do is, we're trying to make more links between the corneal fibers to make it a more firm cornea. So this C3R technique, you can see a lot of more bonds are made between the collagen, usually increases the strength of the cornea by 200%. So from 0.3, it becomes close to 1. So a C3R is an extremely useful method to increase the strength of the cornea, and by doing that, it slows down the progression of keratoconus. So we cannot do a C3R in a cornea with very advanced keratoconus, because the UV light is going to reach the endothelium and cause endothelial damage. So generally, if the cornea thickness is less than 400, we cannot do normal C3R. We can still do, put some distilled water and swell up the cornea and then do the C3R, or put a lenticule on top and then do the C3R. So the total thickness is at least 350 microns. But we cannot do it for very thin corneas. That is why it should be done in an early stage. If we if we wait for too long, then the patient may no longer be a candidate for C3R. And C3R works beautifully. It arrests the progression of keratoconus and little bit reverses the astigmatism. So what we do first is we put the riboflavin. The riboflavin inside the eye causes free radical formation on the cornea, and then the UV light, along with that, those free radicals cause bonds formation between the collagen lamellae. Now, if someone has had a C3R and you look at them on the slit lamp, you'll be able to see the depth at which the C3R has caused the cross links to form. And if you have got more than 50% depth, that is good. The patient should never progress further in his life. So undergoing C3R in early stages helps stabilize vision. Now, a lot of people are very conservative with C3R. They say, okay, let me document progression of keratoconus, only then I'll do C3R. But by and large, most of us feel that why allow it to worsen? If the patient is saying his cylindrical power is increasing, his vision is going down, we know it is progressing. Why make it progress further and stop it there? Let us stop it here. So C3R is increasingly done at the diagnosis of keratoconus, unless the patient is old. Because once you reach 35 years old, 40 years old, keratoconus will slow down on its own. Nature, the normal sunlight, has caused sufficient cross-linking to slow down the keratoconus and maybe stabilize it. So if you're diagnosing someone at that age and you're not sure of progression, maybe you can monitor for progression. But most of the others, we would like to treat at an earlier age, or at diagnosis of C3R, of keratoconus. Just move to the next slide. Now, along with keratoconus, there are two more things we can do with C3R. C3R, we have understood, is a way of preventing progression of keratoconus, but the patient is not able to see. So if the vision is low and we do a C3R, the vision will stay low. It will not improve the vision. It is just going to make sure it doesn't worsen further. So there are two things that can be done. One is the placement of intacs, intracorneal ring segments. These ring segments kind of pull the collagen away. So the central collagen is pulled down. So that improves the vision of the patient with the keratoconus. The second thing that we can do is do a trans-epithelial PRK with the C3R. So the trans-epithelial PRK, okay, this I'll come to a bit later, is, for instance, this is the patient with the keratoconus. Now he has good corneal thickness of 450 or more. We know the cone is here. So we do a little bit of a laser to remove the irregularity of the cornea, not to remove the power, to reduce the irregularity of the cornea. We do a little bit of laser and immediately do a C3R, because laser will be weakening the cornea further. So we do only maybe 30, 40, 50 microns of laser, and then we do the C3R to freeze the cornea in a better position from where it was before. So like this particular patient, post C3R, you can see that inferior steepening has totally gone. He had a lot of inferior steepening there, an asymmetric bow tie. So after the laser, it is a much more regular cornea, and the vision that before was 6/36, now it goes to 6/9. So increasingly, we're doing either a trans-epithelial C3R PRK with the C3R, or we're doing the intacs with the C3R. So the trans-epithelial PRK is just a PRK that I was telling you, but not to remove the power, just to remove the irregularities. And the ablation profile is shown in this diagram. This is what the laser will actually ablate. So this ablation profile is going to take care of only the irregularity, because it is treating only the cone. Normally, you will not have such an eccentric ablation profile for a normal myopia or hyperopia. Now, this PRK is also used, a trans-epithelial PRK, for opacities. Now, in PRK, I showed you that what we do is we put a well here and we put alcohol, we remove the epithelium, then we do the laser. But trans-epithelial PRK means that we are going to do the laser from the surface of the cornea itself, from the epithelium itself, without removing the epithelium. So you can see here that the epithelium is got a very smooth surface, but under that, the cornea surface is very irregular, correct? The epithelium is thick at some points where the cornea is thinner, and it is thin at some points when the cornea is thicker. So if we remove the epithelium, the surface will be much more irregular. So it is better to treat this on the top surface so that you can have a smooth surface later as well. Because if you treat this second surface, those irregularities are going to stay. So that brings the concept of trans-epithelial PRK. First laser, just to remove the epithelium and the mountains of the corneal that are bulging out. Second, to remove the power. In this case, this is just to remove the opacity till the end. So trans-epithelial PRK means you laser the epithelium and then you laser the opacity, or in this case, the irregularity. Then if the patient is not amenable to contact lenses, a lot of patients can't tolerate the contact lenses, then we do something called a deep anterior lamellar keratoplasty. In this, we're removing the cornea, but leaving the desmase and the endothelium, and transplanting the stroma, and the endothelium of the patient stays. Only the stroma and the epithelium are transplanted. Now, this is very useful because all the rejection that takes place is because of the endothelial rejection. And if I think I'm crossing my time. If the endothelium is not transplanted, then the patient does not have a chance of rejection. So that is why we prefer this over a full thickness cornea transplant. So most of these dystrophies, lattice dystrophies, granular dystrophies, macular dystrophies, they require specific treatments and surgeries. I think we're running out of time. Just would like to maybe cover a little bit of limbal stem cell deficiency. Post chemical burns, there is limbal stem cell deficiency, where the conjunctiva then grows over the epithelium. So in such cases, what we have to do is we have to replenish the stem cells at the limbus. So how do we do that? I think I want to just take out this part and the rest of it. We do allogenic. This is the most useful treatment of this. That is that we are going to transplant the stem cells from the limbus of the normal eye to the affected eye. So what we do is we remove all the epithelium from the cornea, we put amniotic membrane, and we take out the limbus, just a small 2 by 2 millimeter from the other eye, cut it into many pieces, and stick it with glue on the amniotic membrane, put a bandage contact lens. So the stem cells will grow within the amniotic membrane and repopulate the epithelium of the chemical injury eye. So I think I'm out of time. I'll just take the questions. There is one eye ASA and one eye ICL done. Is it okay? Yes, if you're having a LASIK done in one eye, which has a smaller power, and ICL in the eye, which has a larger power, that is okay. There is no problem with that. In fact, the ICL eye will see better than the laser eye. Intrastromal rings, how much can they give stability to the cornea? Intrastromal rings do not prevent progression of keratoconus. They are there just to improve the vision. They have not been shown to halt the progression of keratoconus. So C3R along with the intrastromal rings should be done. C3R should never be repeated. If it does not work in the first time, it is not going to work again. Unless it was not done properly, C3R does not need to be repeated. If keratoconus is progressing, C3R has not worked, we don't repeat it. The person who was diagnosed, who has invented C3R, that is his observations. In PRK and DALK, when we remove epithelium, how much time approx does it take to heal? How many days? Okay, so in PRK, the epithelium is removed. It usually takes 3-4 days to heal, but we remove the contact lens after 5-6 days, so that sometimes if it has healed, but it is very loose, and we remove the contact lens, the bandage contact lens, the defect can form again. So typically I remove it 5 to 6 days after the PRK. And how many days CL should be used? So a bandage contact lens, either 14 mm or 16 mm is used. They have more high oxygen permeability than normal contact lenses. This is just for the protection. So people with big eyes use a 16 mm one. 14 mm ones, they sometimes come off. Small eyes, 14 millimeters, there are bandage contact lenses to be used. So if any keratoconus patient eyes are not accepting contact lenses and the patient is not willing for keratoplasty, is there any treatment here which we can do in this case? So it is for those cases that we can use the PRK with the C3R or the Intacs with the C3R. After Intacs, the patient can never wear corneal contact lenses. Semiscleral, he can still. So can Graves' disease cause keratoconus? Graves' disease is hyperthyroidism with protruding eyeballs. It may predispose a little more, but it is not a cause of keratoconus. We don't see too many patients with Graves' disease and keratoconus. So that takes a question. So do I have time to continue, or is it time up?
It's okay, sir. Continue.
Okay. So we just going to cover a little bit of corneal inflammation that is called keratitis. Kera means cornea, titus means inflammation. So diagnosis of keratitis, of course, you have to check the visual acuity, put fluorescent staining on the cornea to measure the size of the defect and see the depth at which the infection is going. If it is going very deep, we can also use ASOST sometimes. Then we have to be more aggressive for the treatment. And then we always do a scraping of the cornea and send it to the laboratory to see which bacteria or fungus is growing. If it is a bacteria, we'll get to know the sensitivity profile of the bacteria, and we can change our antibiotics and we get a much better response in those cases. So scraping should be done in every case of a keratitis to get a tissue diagnosis. Now treatment, one very interesting thing now, if the ulcer is it's not responding to medicines in a few days, a C3R is an extremely good treatment for an infectious keratitis. A C3R kills 99.9% of all infective organisms on the eye, whether it is an early fungus, not a late fungus, and any bacteria. So non-resolving keratitis, even a few days, a C3R is a good modality which can be used. Non-infectious keratitis, inflammation and something, a lot of them require some amount of steroid, can require also bandage contact lenses in some cases. Infection, we have to see the cause. You have to use 1 hourly antibiotic drops. Fungal, you have to use 1 hourly antifungal drops. Viral, you have to use antiviral eye drops and oral antiviral medication. Now in viral keratitis, they tend to recur. So we give them acyclovir oral 400 milligrams twice a day for 6 months or a year so that they don't have recurrent episodes. Every episode of viral keratitis that comes is going to increase the opacity permanently a little bit more. Acanthamoeba keratitis should be suspected if you see a ring ulcer and the pain is disproportionately high. The ulcer does not look that bad. The patient is like, the pain is horrible. So in those cases, we have to suspect Acanthamoeba keratitis, and the treatment for that is slightly different. We use PHMB, propamidine, along with itraconazole. It is a little more difficult to treat. Severe cases may require transplant. If the cornea is about to perforate, then again a transplant has to be done at the earliest. That brings me to the end of my presentation.